witness, please.
State calls Dr. Asif Chowdhury. Can you raise your right hand for me, please? Do you solemnly swear or affirm the testimony you shall give will be the truth, the whole truth, and nothing but the truth, so help you God?
Yes.
Okay. Can you state your name and spell it?
Yeah, Asif Chowdhury, A-S-I-F, last name C-H-O-U-D-H-A-R-Y.
Okay. And how are you employed?
Excuse me?
How are you employed?
I'm a psychiatrist. I'm in private practice.
All right. And prior to being in private practice, how were you employed?
With Wellstar.
All right. And when you were employed with Wellstar, what was your role with Wellstar?
So I was a consult liaison psychiatrist for
And
Kennestone.
for Kennestone Hospital?
Yep.
Can you tell the jury a little bit about your educational background and training that brought you to the field of psychiatry?
Yeah, so I did my medical school training at St. Matthew's University, and then graduated from there and did my residency at University of Missouri, and did my child and adolescent fellowship at the University of Missouri, and then moved back down to Georgia and started with Wellstar.
Okay. And was Wellstar your first psychiatry position after finishing your education?
Yes,
And for what period of time were you a psychiatrist with Wellstar?
for about 5 years.
And what years were those?
Those would be after about 2018, and then up until, I would say about 2 years ago.
Okay. And in your professional capacity as a psychiatrist with Wellstar, what were your duties and responsibilities?
So my duties and responsibilities were, whenever we would get a consult, we would answer the question by the consulting team there, and if it was related to medication management, delirium, or any other mental illness, we would answer the question and then treat the patient accordingly.
Okay. And in terms of your professional capacity as a psychiatrist, what can you tell the jury just generally about what is the field of psychiatry in terms of your expertise?
Yeah, so we deal with mental illness, so common syndromes like depression, anxiety, PTSD, ADHD. In the hospital setting, it's a little different because it can be complicated patients, and so inpatient, outpatient settings are a little bit different there, but common mental illnesses that we'll be treating.
Okay. Your Honor, this time I tender Dr. Chowdhury as an expert in psychiatry. No objection. All right. I want to talk to you a little bit about what your role in this particular case was. How were you employed in December of 2020?
So as a consult liaison psychiatrist with Wellstar.
Okay. And does that have anything to do with issues of like legal competence or legal insanity or legal determinations about somebody's mental state?
So we don't make that determination. In our setting, is whatever question is asked by the primary team, we go in and answer that question for them. So we don't make the determination of competency. That's more of a legal matter there.
And back in 2020, were you employed more as like a clinician and a medical provider?
Yes.
Okay. And so when you say that you were involved in consult psychiatry with Wellstar, how would it come about that you would be called upon to evaluate a patient?
So common things that, for example, the hospitalist team, somebody comes in with suicide attempts or depression or anything like that, where if it's a mental illness, they would consult us to get further assistance in treating the patient or helping with disposition or anything like that. So those are common things.
And back in December of 2020, were there other consult psychiatrists with Wellstar that kind of performed the same function as you?
Yes, I had a partner, Dr. Stefan Rout. So we have a 7-on, 7-off shift, so he would be my counterpart for the other days.
7 days on, 7 days off?
Yes.
All right. So was it just you and Dr. Rout rotating 7 days on, 7 days off?
Yes, and we would have like nurse practitioners that would be under our supervision as well.
Okay. They cannot hear. Can you adjust your microphone a little bit
sorry.
closer to you?
Is that better?
Okay. Thank you. All right. Dr. Chowdhury. Your Honor, at this time I'm going to tender states 117, 118, and 119, which is the the business record certification as well as the complete medical record of Chloe Alexis Driver from Kennestone Hospital.
Any objection?
No, Your Honor, thank you. All right.
You're admitted.
Thank you. Dr. Chowdhury, did you have an opportunity to review the records in this case?
Yes.
All right. And I've tendered states 117 through 119, which is 1,200 pages of medical records. But I also have sort of excerpts from those medical records to just kind of help us conveniently navigate through the volume.
Sure.
In the voluminous records, do you do like consult psychiatry notes and put documentation of what your evaluation was of Ms. Driver into her more thorough medical record?
Yeah, we input it into the EHR, and so anybody can review those, anybody on the team as well, anybody who's allowed to.
All right. And I'm going to, Your Honor, I think just the easy thing to do would be to just tender all of these states 120 through 127, which are just excerpts from the complete record that has already been admitted by business record certification.
Any objection?
Yes, I will reference them as we go. All right, so states
All
tendering
right.
120 through 127.
Are admitted.
Thank you, Your Honor. All right, Dr. Chowdhury. I first want to Is your screen on? Can you see what I'm doing on that screen?
No, it's blank.
Not on. Your Honor, is there a way to turn this screen on? It has text on the bottom, but it says trying to find the transmitter.
I'm not sure I can help with that.
Okay, you can control it up there. All right, well, we'll do it the old-fashioned way, and I will just hand you the physical exhibit. Okay, I will put it on the screen for the jury. States 120. All right. Let me see. All right, Doctor, I'm going to hand you a physical copy so you can see what is up on the screen.
Sure, thank you.
What is states 120?
Excuse me.
What is depicted in this exhibit?
So this is my initial consult note.
All right, and it says there, here at the top, we have Chloe Alexis Driver, Kennestone, and the dates of her hospitalization admit date. But when we scroll down, it says patient name Norland,
Mm-hmm.
and when you go into history of present illness, it says 100 years old. Why is that designation in there?
So that's more of a hospital system kind of policy there, where if they have a trauma patient, they'll put a random name and a birthday or the age if they don't know for
Okay.
multiple reasons.
All right, so when you have a patient that has experienced some type of trauma, they just put a random name and
Yeah.
age designation rather than their actual identity?
Yeah, and they change that usually a few days in.
Okay.
They'll update it.
All right, and on this particular states 120, it indicates that she was admitted on December the 8th and that your consultation date in this record was December the 9th. Was this the first time that you had attempted to evaluate her?
Yes.
Okay. And what did you do after being called upon on the 9th to attempt to evaluate Ms. Driver?
So upon any consult, we end up going to go see the patient and then obtain like collateral information and then information from the primary team, whatever the information that they have.
Okay. it indicates in states 120 that the patient's chart was reviewed, but patient is currently sedated, and that patient was unable to be interviewed at this time. On this date, the 9th, was all of the information that you obtained from her record and from other medical staff?
Yes.
Okay. Is part of your system in reviewing the chart for psychiatric purposes to review toxicology results?
Yes.
Okay, and if you flip to, I think, the 4th page in States Exhibit 120, what can you tell the jury about her tox and lab results from December the 8th when she was admitted?
Nothing was detected there.
Okay, and what are you testing for in those tox results? Is that a pretty broad spectrum of?
Yeah, usually when they come in from the trauma standpoint, this is done by the primary team, so to rule out if there are any other substances on board or anything that needs to be addressed.
Mm-hmm.
So those are typically done, and different tox screens are ran usually, but it just depends on what the ordering provider is actually running at that time.
Okay, and so this panel we see is everything from cocaine, opiates, THC, and nothing was detected in her system. Is that right?
That is correct.
Why is that relevant to you in doing your psychiatric assessment?
Because substances there can cloud our judgment and can play a role in our mental health there, and can also lead on to other symptoms of like hallucination, psychosis, and delusions. And the other factor is if they are positive for certain things, we want to make sure that they don't go through withdrawals or life-threatening withdrawals. So our management can also change based off of that.
Okay. All right. I want to next go to States Exhibit 121 and 122. I will give you a. Yes, I'm sorry. States 121 starts on page 51 of the medical record. All right. Dr. Chowdhury, what was the date of your next evaluation of Ms. Driver?
So based off of this, 12/10.
Okay. So this was 2 days after she was admitted?
Yes.
All right. And you put in there chief complaint. How do you designate a chief complaint, and why is that in quotes?
So typically the chief complaint we get is the patient's own words on why they're here, or if they requested to see us, what are the reasons why. And so the quotes are what the patient has said.
Okay. And this says, quote, "I wasn't supposed to make it." Would that be something that came directly from Ms. Driver?
Yes.
And on this date, the 10th, were you following up from your inability to evaluate her on the 9th, or did she request to see psychiatry?
No, we typically continue on, but yeah, this would be a continuation of the initial consult, yeah.
Okay, from her medical team?
Yes.
Is that standard for anybody that had a suicide attempt?
Yes.
Okay. And then when we look further in the chart, it says the patient was interviewed and chart was reviewed. Patient unable to speak but is able to mouth answers. Communicated with patient via clipboard at bedside. What can you tell the jury about what her condition was in terms of her ability to communicate?
So she was not able to actually verbally communicate during the interview there, but she was writing and mouthing her answers.
Okay. And in this, on the second line of the subjective area, you wrote, the patient was linear and was able to provide details on the events that took place prior to being hospitalized. What does it mean when you state the patient was linear?
So is that her thought process was more focused and kind of orderly there, so that's important if, collecting the history.
Okay. And what was sort of your strategy or purpose in assessing her at this stage? What was it that you were trying to determine?
So the safety and addressing any mood component as well. So in an individual, we look at disposition as well after a suicide attempt, if they need to go inpatient or where they would be going next. And so we look at all areas, and then looking at medication management if it's indicated as well.
Okay. This summary where it starts with she reports being in a relationship with a male individual for 4 years. Is this summary, are these your words summarizing what information she gave you, or are these her words?
So these were basically a summary of her words, so kind of incorporating it all into some, a format that could be understood and kind of make sense there.
Okay. And in the initial paragraph, it says patient via clipboard at bedside. Was she able to sort of coherently and logically respond to your questions in writing?
Yes.
Okay. And did you collect those writings and make them a part of her official medical record?
Nursing did, I believe.
Nursing did,
Yeah.
okay. And is that what is depicted in State's Exhibit 122?
Yes, I believe so.
Her handwritten responses?
Yes.
Okay. And I want to go through the things that she wrote. You've told us that you kind of summarized the things that she wrote here. What, from your summary, did she tell you was the motivation for her killing her daughter?
It was to get out of the relationship, that she felt the only way out was taking her life, or taking the baby's life and her life.
Okay. All right. I want to go to her responses. In State's Exhibit 22, Mr. Hathaway, this is page 1262 in the record. All right. So when you were communicating with her, were you verbally asking her a question and then she was writing the answer?
Yes.
Okay. So when we look at State's Exhibit 122, it is multiple pages of writing. Did you document anywhere what question you had asked that prompted these answers?
Typically, it's all kind of within the narrative of the subjective. So we don't usually put like this question and then the answer tied to it there, but it's usually all kind of asked together.
Okay. So, for example, if we look here at page 1264, there's a writing that says, do you know if I'm going straight to prison or leaving here first? Can you tell from your record whether that would have been in response to a question or if that was a spontaneous statement?
So, could you repeat the question there?
Sure. There's a lot of writing on these pages that doesn't all connect. It's not a complete narrative.
Yeah.
So what I'm trying to establish for the jury and help them understand is, were these writings in response to a question that you asked, or was she just wanting to tell you things?
I believe this was a question that she asked.
This was a question that she asked.
Yeah.
Would you ever introduce the concept of prison or incarceration to a patient that you were evaluating?
No. I don't do
Okay.
that.
And why not?
Because there's no therapeutic benefit of saying that, hey, are you going to a prison, or do you know if you're going to jail? It's more of us deciding what the safest place for the patient to be, and if, say for example, jail or anything like this wasn't in question, we'd be looking at either inpatient hospitalization if a patient is acutely in danger to themselves or others there. So we don't ever introduce if they're discussing jail or things like that. There's no therapeutic benefit there.
Okay, so this would have been something that she was concerned about at that moment that she just asked of you.
Yeah, and it's quite common for a patient to ask, or where am I going next, or when am I getting out of here in a hospital setting. So.
Okay, all right. I'm going to go up a little bit more. There's a statement here that says, what do you mean prescribe? Would that be in response to something that you asked her?
Yeah, so typically we ask like past psychiatric history, if we've been on prescribed medications, or if we take any other like substances as well too.
Okay. Do you know what the statement 8th grade for fun once was in response to?
That may be more so of like substance use.
Okay. And then she wrote, we both disagree with pharmaceuticals. Do you know what that was in response to?
Her husband and her, their thought process behind like using medications.
Okay. And did you discuss with her extensively the prospect of putting her on medication?
Yes.
And at this time, on December the 10th, did she express any feelings to you about whether she wanted medication?
She did not want medication.
Okay. And did she ever state to you why?
That it wasn't in their belief system.
Okay. Right. And let me go back. This note that just says "My daughter is dead." Do you know what that is in response to?
Not specifically, no.
Okay. All right. This statement at the top that says, "I think Grace changed them already." Do you know what that was in response to?
I don't know.
Okay. Was there any medical provider named Grace, or was this in response to any type of medical need?
I don't believe so, but I don't know.
Okay.
Yeah.
And then she wrote, "I hurt myself and my baby." Would that have been in response to an inquiry?
Yes, sometimes we ask, like, do you know what brought you into the hospital? So that may be in relation to that.
Okay. And then she wrote, "I was stating for months I couldn't handle my husband's lifestyle anymore." What would that have been in response to?
That what led up to our hospitalization.
And is that, when you were questioning her, is that, when you say what led up to her hospitalization, are you specific about what led to the suicide attempt or what led to her being physically present in the hospital? Would this be a statement as to her motivation for the act?
So the goal is to kind of assess the timeline of what has been going on, what kind of led to our present moment of being assessed at that time. So why are they in the hospital there? So a lot of times patients will kind of give a timeline of, hey, I've been feeling depressed for some time, or these symptoms have been going on for some time, and now I'm here, secondary to numerous different things.
Okay. Sorry, I'm just trying to zoom in for the jurors so they can see better. This portion that says, well, maybe I shouldn't press my luck. He collects people to live with us, and after we got 3 more people, I started perceiving them ganging up on me and leaving me out, changing stories. Would this have been in response to a question or about her mental state? Do you have any recollection of sort of how all these pieces of information fit together in response to what question?
I do not recall
Okay.
what the question would be.
All right. There's multiple pages of writings here. I want to talk to you about this portion at the bottom where she wrote, "For the first 2 years, not so much, because it was just us traveling. But once he got people listening to him more, I started feeling scared and was begging for attention for us to be with baby." Do you know what that was in response to?
It was likely asking if you felt safe in the relationship.
Okay. And,
or if there was any safety concerns.
okay. And so she indicated that that things had changed because there were more people in the group now,
Mm-hmm.
and she had been begging for attention for her and him to be with the baby?
Yes.
Okay. And then over here on the side, do you know what this note was in response to that says, "Eventually within the last 2+ months I started taking CBD and I was becoming paranoid"?
So I'm not sure what that was specifically in response to, or if it was just a statement that she was making in regards to asking about substance use.
Okay. Anything about her mental state when you were asking these questions and she was responding? I know you put in your record that her thought process was linear,
Mm-hmm.
but did you document anything in there about whether you had concerns that she was actively delusional or experiencing any type of hallucinations or delusions at the moment that you were evaluating her?
Not at that moment that anything kind of stood out to me.
Okay. Did she seem coherent, capable of understanding your inquiries, capable of giving logical responses?
Yes.
Okay. Did she describe to you, and I think you kind of summarized it in States 120, did she describe to you sort of the back and forth of her wanting to leave the group and coming back to the group?
She did talk about her inability to leave, or the hold that the other individual had on her.
The hold that he had on her?
Yeah, in the meaning of like where she couldn't leave the situation.
Okay. And I think that you put in your summary of her motivation for the act of her harming herself and her daughter, is that she felt like that was her only way out.
That is correct.
Okay. And this portion at the top where she said there was no escape for us, was that consistent with sort of your overarching summary that that was her only way out?
Yes.
Okay. All right. And then this portion where she said basically he's supposed to marry 1,000+ wives, take over the world, and there's only 169,000 living souls. What was this in response to?
So this may be in response to asking more about kind of the environment that she was in and their belief systems.
Okay. So this portion here, if we go down a little bit further, it says, turned me into really mean and cold for the righteousness of the Holy Spirit. Then it was just us, but then once he got people, he flipped almost all the info he fed me in the beginning. Do you know what this was in response to?
So it would be more so of what their belief system was and what she was being, either told or told to believe.
Okay. And did she express that things changed for her when more people joined the group?
Yes.
Okay. This portion right here, this paragraph that starts with, I was not supposed to live, do you recall if this was in response to a question?
Yes, it may be a response to, are you happy to be alive?
Okay. And she indicated I was not supposed to live. I wanted to be with her because I do believe I'm too crazy at this point to go on, especially after killing my own daughter. What is this portion that says, I'm pretty sure I was, though, when I asked sometimes they'd confirm lights flickering? What does that mean? Do you have any recollection?
So it may be related to having any sort of hallucinations.
Okay. And when she wrote they'd confirm that lights were flickering, do you have any idea what that meant?
So, or it may be more so of like she was seeing things and confirmation by others in the home that yes, that is actually happening.
Okay. And this says, I have several times, my big attempt was just a week ago. Was this her describing sort of her thoughts surrounding her her inability to leave the group?
Yes, I believe so. Or it could also be in relation to if we've had previous suicide attempts. That is a question we typically ask as well.
Okay, so you don't know if this was in reference to an attempt to leave or a prior suicide attempt?
Yes.
All right.
But based off of that, it does look like trying to leave the situation.
Okay. And then she wrote something here about taking out a $150,000 loan in her name.
Mm-hmm.
Do you know if that was in response to a question?
It may be more so related to why did we stay back, or were there other reasons that we had to stay?
Okay. All right. What was your kind of assessment of her mental state at this time? This was on the 10th of December, 2 days after she was admitted. I know you've already testified that she said pharmaceuticals were against her belief system and that her motivation for murdering Hannah was because she felt like that was their only way out. What was, from a psychiatric perspective, sort of anything you documented about concerns for her at that point?
Yeah, our concerns were that she was not safe for discharge. So meaning that if an individual had a suicide attempt, that we would not just clearly let them just go home after the hospitalization.
Okay. But did you document any type of active delusions, hallucinations, anything like that at that time?
Not at that time.
Okay. I want to talk to you about State's Exhibit 123, which I'll pull up. Let's try the way that starts on page 61 of the record.
Thank you.
All right. So we talked a little bit about Dr. Rout,
Mhm.
and this is his record. But I want to discuss with you this note here on page 61 of the record. It says patient is able to mouth words but withdrawn with poor cooperation. She is not interested in medications or therapy and reportedly has beliefs that are counter to allopathic treatments and mental health treatment. Was this documentation by your counterpart, Dr. Rout, consistent with the information that she provided to you on the day before, the 10th?
Yes, I believe so.
Okay. And then under medication plan and recommendations, did he document continue to hold off on meds, patient refusing?
Yes, that is correct.
Okay. All right, and then this last portion, can you read the portion under subjective current status?
Where it starts from withdrawn.
Yes.
Okay, withdrawn, flat, poor eye contact, does not cooperate to write for interview, just intermittently mouths responses, not interested in talking, taking meds, or participating in therapy, still wishes she had died with her daughter.
Okay. All right. And handing you State Exhibit 124. Tell me what that is.
So this is a progress note.
And is that a progress note from you assessing her?
Yes.
I'm sorry, page 84.
Yes, it is.
Okay. And tell me, after yourself and Dr. Rout had evaluated her, obviously you got the bulk of her responses and writings in her initial workup on the 10th.
Mm-hmm.
What is the procedure for continuing to go back and assess and evaluate a patient like Ms. Driver?
So, excuse me. So based off of acuity and like what it comes down to, like if medication management, we may see patients frequently, like every day, every few days until we sign off on the patient. So it all just depends on the severity of her symptoms.
Okay. And was this follow-up consult on the 14th primarily about whether she needs medication management?
Yes, if somebody is refusing medications, we'll still follow up to offer those services or other therapeutic interventions like bedside counseling as well.
Okay. And did she avail herself of any of that?
She did not want any medications. Yeah.
Okay. And what did you document under your subjective current status on this consult on December the 14th?
So would you like me to read that?
Sure, yeah.
Okay. So a patient is trached and has a difficult time responding, however, is able to mouth answers. She denied suicidal ideations, homicidal ideations, auditory and visual hallucinations, and discussed again if patient would be agreeable to start medications. She refused and stated that she didn't want to be on anything based on her beliefs. No acute concerns noted by nursing staff and officer with patient.
Okay. And was there anything about her mental state at this time that was different from when you initially assessed her on the 10th, or was she substantially in the linear, capable of following your inquiries?
Yeah, it was similar.
Similar? Okay.
Yep.
going to hand you State's Exhibit 125. All right. This is not your note, but all the records are in. Okay, this is a progress note that we see here on the screen is dated December the 18th of 2020, which is 10 days after her admission to the hospital. Can you read, starting with patient refuses, in terms of what the progress note was from her care?
Yeah, so patient refuses all medication, crying, repeatedly saying, I just want to go back, I just want another chance, I'll be good. Patient refuses any medication for relaxation.
Okay, and was this by the nursing staff?
Yes,
Okay.
I believe so.
Okay. All right, and then I want to hand you State's Exhibit 126. And that is starting on page 102. You put on here chief complaint, I need to rewind back. What can you tell the jury about this consultation on the 18th with regard to when Miss Driver learned she was being charged with murder?
So based off of this, there is notable decompensation from my previous visits with her.
Okay, and you put in there she was told yesterday about her charges and decompensated.
Mm-hmm.
And so between the 8th and the 18th, did you attribute her decompensation based upon your consultation with her team to her learning of the charges against her?
Yes, that's what it appeared to be. That was the only change at that time.
Okay. And what did you document about any delusions that she had at that time?
So based on this note, but the patient is delusional throughout the interview. She's fixated that we are living in hell and that we are all actors. She says that this is a movie playing and that we can rewind from the beginning. She states, when you die, you don't really die. She was pressured and anxious, excuse me. And she was told yesterday about her charges and decompensated.
All right. At any time, did you ever either hear her, was she able to speak at this time? Had her trach been removed, do you know, or was she still communicating with you in writing?
She was able to communicate at this time, I believe.
Okay. And so the delusions that you documented are that we are living in hell, that we are all actors, that this is a movie playing that we can rewind, and that when you die, you don't really die. Did she articulate at any time any delusions related to the baby or her daughter?
Not based off of this note, no.
Okay. And then when we go through the mental status exam, were these things that she was cooperative in providing responses to? For example, it says, whether she has suicidal ideations or homicidal ideations, and you've indicated denies.
Mm-hmm.
Would those be questions that she was capable of answering for you?
Yes.
Okay. And then you put thought process disorganized. Does that relate to your sort of summary of she was pressured and anxious?
Yes.
And what does that mean to be pressured and anxious from a psychiatric standpoint?
Yeah, so from the anxious standpoint is that the patients, when we're looking at their affect is how they present to us. So at that time she was anxious, and the thought process being disorganized, meaning that we were kind of jumping from one thing to another and things were not kind of connecting or linear or goal-directed.
Okay. And based upon your and Dr. Rout's, well, let me ask you this. When you said you and Dr. Rout were 7 days on, 7 days off,
That's correct.
and from these records, we know Ms. Driver was hospitalized from December 8th until December 22nd.
Mhm.
So between December 8th and December 22nd, would it have been a consistent 7 days on, 7 days off with you and Dr. Rout?
Oftentimes, yes. There are times where we may swap over. We provide coverage for each other because holidays or other things like
Okay.
that. Yeah.
So she was in the hospital for about 2 weeks. Based on your experience with her, would you have reviewed and consulted Dr. Rout's records as well?
Yeah, so we continue, whenever we transition off, we update each other on the patient list, as
Okay.
long as the patient is still active on our list.
Okay. And was she consistent in her statements to you and Dr. Rout about her belief system and not wanting to be on medication?
Yes, she was.
Okay. And then States Exhibit 127. I know this is not your note, it's a physical therapy note, but can you see that on the screen? The PT note?
Yes, I can. Yeah.
Do you mind reading that?
Yeah. Attempted PT this morning. PT deferred mobility, stating that she has no reason to walk since she'll be sitting in a jail cell for the rest of her life. We'll follow up one more time to encourage participation. If she continues to refuse, may discontinue PT next attempt.
Okay. And this note was from December the 22nd?
Yes.
Okay. And beyond sort of assessing her initial mental state and counseling her about medication options, which she refused, was that your limited role in her treatment and care?
That is correct.
Okay. Have you had any involvement at all in the legal proceedings or the legal side of competency, sanity, any of that?
No.
Okay. Is that your wheelhouse, so to speak?
No.
Okay. All right. I have nothing further for this witness.
Okay. Do we need the jury to step out, or you've got?
I think I should be okay if you just give me just a second.
Okay.
Good afternoon.
Good afternoon.
My name is Angela Trethway, and it's nice to meet you.
Nice to meet you as well.
All right, so let me begin by asking you this. When you conduct your mental status exams, you are relying on a patient to verbalize or communicate with you in an accurate manner, correct?
Yes, we're looking at that. Yeah.
Okay, so it's in your experience, can somebody actually be experiencing auditory or visual hallucinations and not report that to you?
Yes, that can happen.
Okay. And that wouldn't be something that you would find inconsistent with treating a psychiatric patient?
Repeat that one more time.
So, do you find it fairly common that a psychiatric patient may not accurately report the actual symptoms that they're experiencing?
When it comes down to specifically hallucinations or just in general?
In general.
Yes, that's possible.
Okay. So it's entirely possible that in any of your examinations of Ms. Driver, that you were relying on her to be accurate with you, and that's how you proceeded, correct?
Yes.
So you don't have any independent way of knowing whether or not she's experiencing any type of delusions or auditory or visual hallucinations unless the patient verbalizes that to you, correct?
Well, we have nursing staff, other staff that are monitoring her, so oftentimes they may suggest a patient is responding to unseen stimuli, or they've been like talking to themselves in a corner to a direction where there's nobody there, and so they are usually being monitored, and they're often, there's sometimes cameras there if there's no individual monitoring them.
Okay, but what I'm asking you, and at least not noted in any of these records, you were not being told by any other staff members or anything that those things were something that they were reporting with respect to Ms. Driver.
That's correct.
So in this particular instance, the only thing you could rely on was what she was actually stating to you in these interviews, correct?
That's correct.
All right. And one of the first things you did when you assessed her initially, I think it was December the 8th, is you noted reviewed all of the other staff members' records, correct?
Yes.
And in those records, you were able to determine what the extent of her injuries were, correct?
Yes.
And those injuries were described as self-inflicted, correct?
Yes.
Do you remember how many stab wounds that she had
I
in
do
her
not.
neck? Okay. I'm on page 7. Okay. May I approach the witness?
Yes.
So 5 stab wounds.
Okay. Do you remember if there were any other additional wounds to her that you recall?
I do not recall.
I'm going to take that one for you. Thank you.
Are you tendering that, or?
No. If the medical records reflected that she also had a stab wound to the chest, you don't have any reason to dispute that, though, correct?
That's correct.
Okay. And you also noted in your initial assessment of her that she actually had scars or marks on her own wrists. Is that correct?
I would have to look at those notes. I don't recall.
Okay. You indicated once that a patient would be stable, that there would be somebody that would sign a 1013. Can you explain what a 1013 is?
So a 1013 is an involuntary hold. So if somebody is, say for example, suicidal, that we would be holding them in the hospital so they don't have the right to leave.
Okay. This is page 1261. We're on 4. Okay. I'm marking this one as defense exhibit number 4. May I approach the witness?
Yes.
Can you tell the jury what that document is?
So it's a 1013.
Okay. And what is the process behind getting a 1013?
So any physician or psychologist or other staff can place an involuntary hold to hold the patient against their will and not be allowing them to discharge.
Okay. And that's kind of a process that involves a court, correct?
No, it doesn't require the court to step in unless we are escalating to different levels of involuntary holds.
Okay, but that is a procedure that you put in place typically when you see cases that are suicide or something else like that.
Yeah, if there's acute safety concerns, imminent risk to harm for themselves or others, yes.
Okay. We would move to tender defense for as evidence.
It's admitted.
Thank you. So your next contact with Ms. Driver was on December the 9th, correct?
I believe, I don't have my notes in
Okay,
front of me,
that's,
so.
so this, the day she came in was December the 8th, and you were
Yeah.
unable to assess her at that particular point in time, correct?
Yes,
And were you aware that at that time that she was being given medications by other doctors?
I believe so, yes.
Okay. And at that particular point in time, the staff had determined that she was unable to medically make those kind of medical decisions about whether or not to take that kind of medication, correct?
Correct.
Okay. And you also indicate that you prescribed, I think it was Haldol, PRN?
Yes,
Can you explain what PRN means?
as needed.
Okay. And do you know if any of the, in this particular case, if that was ever administered by any of the nursing staff?
I don't have that knowledge.
Okay. Would that be something that would have been taken orally or intravenously?
In her case, likely IV or intramuscular.
Okay. And who made the decision, who would make a decision as to when it would be needed?
The treating staff at that time.
Okay. But there was a prescription or an order from you for the Haldol at that particular time?
I believe so.
Okay. And then Ativan as well?
Yes.
And Ativan is used for what?
It's to help in the setting of anxiety, so we often use Haldol and Ativan together.
Okay. Now, when you order something PRN and you've determined that a patient does not have the ability to make their own medical decisions, is that something that you or the staff can decide to administer? That you could have any staff member can administer without getting permission of the patient?
Yes.
Okay. And what's the purpose of Haldol? What does that treat?
So it's a first generation antipsychotic that we utilize in agitation. We use it in schizophrenia as well, or other mental illnesses.
Okay. And you already said that Ativan is for like anxiety or anything else related to that. Okay. You again saw her on December the 10th, and that's when you did kind of a more thorough, I guess is the best way to put it,
Sure.
interaction with Ms. Driver. And in that particular point in time, she still had the trach, correct? I'm sorry, you have to answer
Yeah.
out loud.
Yeah, I
Oh,
believe so, yes.
Okay, and then still was taking the pain, being administered the pain medications, and to your knowledge?
So other pain medication, I'm not aware of what she was getting.
Okay. One of the things you told us earlier was that she was not able to speak, but was able to mouth answers, correct?
Yes.
All right, and then part of the thing that because of her current condition, was it you or a nurse that gave her the paper and pen to write with? Do you recall?
I believe it was nursing staff.
Okay, let me pull this up. That's not it. Is it 120? Okay. Do you have the handwritten notes still up
I
there?
do not.
Okay.
They're
Oh, they're in order, okay. May I approach the witness?
Yes.
Okay. What's that? Yeah, I'm trying to. Tech is not my thing.
The screen is working now, by the way.
Oh, the screen's over there?
Yeah.
Okay, good.
Yeah, I just had to restart it.
All right, so I know that you said you don't recall the specifics with the order or what your specific questions are, correct?
That's correct.
All right, but some of the things that you were trying to assess, I think you indicated, was like her current mental status and, trying to develop some background information as to how she got there that day.
That's correct.
Okay. And she told you, at least in these handwritten notes, she said, I hurt myself and my baby. I was stating for months I couldn't handle my husband's lifestyle anymore. He called people to live with us, and after we got through more people, I started perceiving them as ganging up on me and leaving me out, changing stories.
Yes.
And I guess in response to further questioning, she said, if I didn't listen to my husband to go sit or stop talking, he started hitting me after he had 4 individuals by his side. So when she disclosed to you that she had been at least physically abused, was that what prompted the next line of questioning about the nature of the relationship and whether or not she felt safe?
I believe so, yes.
Okay. One of the things she did relate to you on that particular day is that she did have some feelings of being scared, and that she had been taking that CBD and was becoming, I can't read part of it, but something paranoid is that correct?
That is correct. That's what's written there, yes.
Okay. And I think you told Ms. Gropper you didn't remember what this statement was in response to?
Which statement?
The my daughter is dead, the next page. I'm sorry, I'm scrolling up.
Yes, I'm not sure what that is a response to.
Okay. And then if you could flip to the next page, I believe it's page 1264 in your packet.
Mm-hmm.
Some of the things that she continued to explain to you by writing in response to your questions were about the relationship was that he never allowed her to get a licensed car or anything or job until they were homeless at one point, I guess.
Mm-hmm. Yes.
And that she communicated to you that she was 17 when she met him and had the baby a few months after.
That's
He was
correct.
19. She also reported to you that he would hit her or threaten her and keep her there even when she wanted to try to.
That is correct.
Okay. And then you were talking, I guess, about part of your process in this is to try to, educate patients of, experiencing psychiatric issues for the first time about the benefits and side effects of medication.
Yes, we often discuss all treatment options.
Okay. Some of the things that she also talked to you about was a different belief system about how the world was and spiritually. She seemed to talk about that in the context of we, correct?
In the context of what?
Of a we instead of just me.
Yes.
She was referring to both her and her husband.
Yes.
Okay. If you could turn to page 1265, it should be the next one.
Mm-hmm.
All right, and she had previously, in questions leading up to this, had indicated to you that they just didn't believe in pharmaceuticals or doctors or anything else like that, correct?
That is correct.
All right, and then this next step in these notes, she seemed to be kind of talking about some things, including that he had taught her that everybody was Satan, parents rape me, the CIA's after us, and entities controlling her unless she listened to him. And I guess this is, again, in response to questionings about the relationship?
I believe so.
Okay. And in these statements, it's a clear indication that she is communicating some concerns or things that she felt in this relationship with her husband, correct?
Yes, correct.
All right. And that she also kind of talked to you about some beliefs about what happens when you die and all of those things. And those, would you agree with me that some of the things that she's talking about with the CIA and Satan and her belief systems about death are not necessarily consistent with that of somebody in a good mental state?
Well, that can be relative. They can be non-bizarre delusions as well too, where like the CIA can be after us. So versus if somebody said that, hey, aliens are after me or something like that. So.
Okay, but it also could be indicative of somebody having some of those paranoid type thoughts that she was referring to previously.
That is possible, yes.
Okay. And then she also talks about how her husband had tried to give her his own diagnosis.
Yes.
Okay. And that he also shared that something about beliefs regarding heaven and hell.
Yes.
Okay. And that, do you remember talking to her about how she described her marriage? Let's scroll down here. In terms of it being a different document. Do you recall what that explanation was?
Yes, like in the sense of like if they were married, and so I believe that it was in reference of that they followed a different kind of document for marriage.
Okay. All right. Part of your job as the resident there at Wellstar is not necessarily to.
So not a resident, attending.
I'm sorry,
yeah.
attending, sorry. Is not to necessarily diagnose somebody with a specific disorder, correct?
So as the council liaison, it's more addressing the underlying, the question that is asked by the primary team, but we do try to provide a preliminary diagnosis of what we believe the patient may have at that time.
Okay. And some of the things that you talked about in your notes or your records here is that you had concerns that there was an adjustment disorder with mixed disturbance. Can you explain what that means?
Yeah, so the adjustment disorder meaning that there has been recent stressors that the patient has been exposed to. And so it was a diagnosis that we put down preliminary.
Okay. And you also noted the physical and emotional abuse victimization?
Yes, based off of the history that was presented.
Okay. And that some of the things that you wanted, that you felt needed further consideration were the PTSD, which is the post-traumatic stress disorder.
That's correct.
And then an unspecified depressive disorder, correct?
That's correct.
But you continued the Haldol, PRN, and Ativan as
yep.
needed throughout this process, correct?
That's correct.
Okay. Jeff, can you help me get it back? Or somebody? Sorry. Okay. You would agree with me, Dr. Chowdhury, that a person's psychiatric condition can vary across different points in time and intervals, correct?
That's correct.
Okay, and if somebody is not being actively treated, i.e. refusing medication, that can still continue to happen even though you're seeing that patient consistently over the course of their hospitalization?
Yes, we can.
Okay, so the fact that if someone doesn't report auditory or hallucinations or delusional thoughts initially doesn't mean that that can't develop or progress as they continue to be hospitalized, correct?
That's correct.
All right. In this particular case, you went again and saw her, I believe it was on the 14th. Let's get to that. '24. Yeah. Okay, I'm 124. May I put your witness? Yes.
Yeah.
On this particular one is from December 14th, and at that point in time, you did another mental status exam, correct?
That's correct.
And at that particular point in time that you indicate she was denying any type of suicidal or homicidal ideation or the hallucinations, correct?
Correct.
Still didn't want to continue on any kind of medication.
That's correct.
And that again, all of those things were something that needed to be self-reported, right?
That is correct.
Okay. Are you aware that there were other providers, at least notes, that she continued to express concerns about suicide?
Sorry, say that again.
Around that same time, were you aware that she had continued to express concerns about or desires to commit suicide?
I'm not aware of that.
Okay. This is Katie Page. I'm gonna skip it. I know Ms. Gropper asked you earlier, but you were talking about that she was delusional or appeared to have reported delusions for the first time on December the 18th of 2020. Do you recall that?
I do, as long
Okay,
as.
let me come up there with that one. No, it's not 125. May I approach the witness? Yes. At this point in time, you don't have any recollection of whether or not she had been given any of the Haldol or anything that you had prescribed as PRN?
I do not.
Okay. And at that point in time, she did convey that she thought we were living in hell and that everybody around her was actors.
That is correct.
All right, and at that particular point in time was the first time she actually verbalized, at least to you, that she was having those visual hallucinations and delusions?
Yes.
All right. And continued to refuse any type of treatment or intervention, is that correct?
That's correct.
All right. Do you recall reviewing any notes in this particular case about her discussions with any of the other providers, like the speech language pathologist or anything else like that?
I do not recall.
Okay. This is page 205. I'm gonna do, mark it as defense 5. I apologize, we had the same set of records, so I had to pull some out, so,
No worries.
all right. Yeah, yes. Show you where I'd like you to read into the record. Can you read to the jury and the members of the court what the patient's verbalization was at that particular point in time?
Patient verbalizing, let me die, please let me die. I want the world to start over, I want my baby. Everyone out there hates me and wants me to suffer. Patient alternating between intense crying and completely flat affect in an instant.
Thank you. I could just have 1 second, just make sure. I don't have any further questions. Thank you, Dr. Chowdhury.
Redirect?
Let's just make sure I have these back in the right order. I think I got that right. Thank you. D5? I'll move to admit D5 if I didn't do it already. I don't remember.
It's in there.
Thank you.
Dr. Chowdhury, I just wanted to follow up on something Ms. Trethaway asked you. She was talking to you about delusions, and she asked you specifically about the notation of her thinking that the CIA was after them. And your response was something to the effect of, like, not necessarily, it's not the same thing as if she said aliens were after them. Can you explain that a little bit for us?
So yes, we can have different kinds of delusions. So there could be non-bizarre or bizarre delusions. Like we could feel like, hey, my house is tapped, which could possibly be, versus something that would be out of character, like, hey, there's another entity around the world or something that's spying on me or things like that. So delusions can be different kinds.
Okay, and what is a delusion?
A false fixed belief.
Okay, a false fixed belief. And if somebody has a untraditional worldview, is that necessarily a delusion?
No.
Are you familiar with the people that call themselves flat earthers?
Yes.
Okay, and they have whole conventions of like tens and hundreds of thousands of people that think the world is flat?
Yes.
Are all those people delusional?
No.
Okay. And in your field of study, is it difficult to assess what is a genuinely held worldview versus something that's a delusion of the mind?
Yes, it can be difficult. Yes.
Okay. I have nothing further.
Okay.
Any further cross-examination?
Dr. Chowdhury, you'd agree with me that the CIA generally doesn't follow the average person, correct?
I would agree with you. Yes.
And so that could be some sort of false delusion, not necessarily a belief, correct?
Sure, it could be. Yes.
Thank you.
Anything else of this witness?
No, Your Honor.
You can step down. Thank you.
Thank you.
Counsel will come forward, please.